For many patients, trying to get pregnant can be frustrating, and as providers, we have an opportunity to guide them and help them optimize natural fertility as they plan their future conception. Welcome to Clinicians Roundtable on ReachMD. I'm your host, Dr. Hector Chapa, and here to discuss ways to maximize natural fertility is Dr. Naomi Whittaker, a private practice OBGYN physician in Pennsylvania who has evolved her clinical practice to include a structured, evidence-based model to maximize fertility using NatPro technology. Dr. Whittaker, welcome to the program.
Thanks so much for having me.
This is very important because in a time that you would think would be, in general, a lot of fun trying to conceive, it can actually be very frustrating when results just aren't there. So, Dr. Whittaker, let's first clarify the difference between maximizing natural fertility and a set diagnosis of infertility. While they may sound similar, can you explain how they actually differ?
The way that they sound similar is that both of these groups of people are trying to conceive. However, one group understands that they have issues conceiving and that they're having or experiencing infertility. And there's another group ready to conceive and they haven't yet tried to conceive yet and have made that decision and are ready to maximize fertility, as in ready to achieve. And of course, everyone has the goal of a healthy pregnancy.
Now, when it comes to maximizing this natural fertility, the American Society of Reproductive Medicine, or ASRM, actually references the importance of timed intercourse during a woman's, quote, fertile window. But what does that actually mean? Can you help explain that a little bit more for us?
Right. So for the definition of infertility, we talked about a year of random acts of intercourse. Now, it's very different when a couple understands the actual fertile window, which is actually much more narrow than the entire cycle. For men, they're always fertile, but for women, if they have a normal physiologic menstrual cycle, they should be ovulating once a month. And so this means there's one window of fertility. This window of fertility is actually approximately 6 days long. The 6-day window includes days leading up to ovulation, and these can be identified with the cervical mucus pattern. And so the cervical mucus actually is present there and changes as estrogen rises, and it actually has a purpose to nourish sperm, provide channels for the sperm to flow to direct healthy sperm through these channels towards the oocytes, as well as lengthen the lifespan of the sperm, which otherwise would die quickly in a hostile pH of the vagina. But this changes the pH to keep them alive for up to 5 days. Then the lifespan of the egg is 12 to 24 hours. So if you combine the 5-day window of mucus, enhancing the lifespan of the sperm, and the 12 to 24 hour lifespan of the egg, then you have a 6-day window of fertility.
Now, so I think that's a very important point to clarify because out of the entire, say, typical 28-day cycle, which we know, of course, many women don't have, there's really a fertile window of only 6 days with a greatest chance of conception, as you said, really about 24 hours before ovulation. So that's the big difference. It leads me to my next point, which is how many times should a couple have sex? Can you tell us what the data has regarding coital frequency in that fertile window and chance of conception?
Some people state that seminal fluid parameters go down with daily intercourse. That's not the truth. Daily intercourse is not shown to reduce seminal fluid parameters. And in fact, abstinence of 5, especially up to 10 days, can decrease seminal fluid parameter. So daily intercourse is okay. Now, with the added component of the emotional and behavioral aspects and psychological aspects of infertility, which we must take into account, which can affect, even for men, erectile dysfunction potentially with the pressure of intercourse daily. It's okay, according to the data as well, as if couples spaced every 2 to 3 days, and really focus on that timing near ovulation instead of really coital frequency of every day and putting that pressure on that couple.
Right. And I think that's a good clarifying point there, because I'm often asked by our residents, what do we say is the most appropriate frequency? And the most appropriate frequency is whatever they both choose to do. And that's where the art of medicine comes in. I mean, for sure, we can talk about the data, and sperm parameters do not decrease with daily ejaculation or daily intercourse. That's the science. But the art of medicine is have that discussion with them. As long as they're having intercourse in that fertile window, whatever is correct number for them is the correct answer. For those of you just tuning in, you're listening to Clinicians Roundtable on ReachMD. I'm Dr. Hector Chapa, and I'm speaking with Dr. Naomi Whittaker about NAPRO technology, a model approach to maximize fertility. Now, that's a great segue, Dr. Whittaker, to get into something that you've done extra work and an extra training with, which is NAPRO technology. Well, what exactly is NAPRO?
It's a small subspecialty, and it stands for Natural Procreative Technology. So to contrast that with assisted or artificial reproductive technology, and its basis is on a woman charting with the cervical mucus method called the Creighton model system of fertility awareness. And so she is taught through structured classes in a standard scientific way to do observations of bleeding patterns, mucus, and other external observations. And she's able to objectively write this down in a standardized way on a chart. And so she's also given a lot of education about the physiology of the menstrual cycle, cervical mucus. And so she is able to plot this down. And I was trained in a fellowship to interpret this data to be able to use it for diagnostic purposes, so be able to do testing based on specific cycle days, especially based on her individual biomarkers. In addition, I'm able to use that data to treat cooperatively with the menstrual cycle, to work with it to address underlying issues.
So if a patient comes in and says, I would like help, I'm in my preconception visit, I'm thinking about conceiving soon, how would you integrate NAPRO technology or instruction into a patient who's trying to get more information? How many classes? I mean, is this a big patient buy-in in terms of time to do this? Is it hard to learn?
It's not hard to learn. There is some time commitment, and there's more time up front. There's an hour introductory session, which is free. And we do offer it through our clinic, and there are practitioners or Creighton model practitioners online all over the world who teach it in various languages and can teach it through telemed. In some cases, it's covered by insurance, especially if they are RNs.
So is this a option of treatment in lieu of medication or to be used together with medication? Or how do you make that distinction between NAPRO applicable therapy and when do you use medication?
Sure. So I always like to start with the data, being able to see a kind of their fifth vital sign, as FACOG calls it, of the menstrual cycle. I'm able to use it for women who are single and having issues with their menstrual cycle. And it helps me often predict that they may have fertility challenges. I like to use it for women who are starting to try to conceive because they can time intercourse appropriately and they can plan their pregnancy, even their due date. And I like to use it for women having issues. And then we can see their cycles transform as they undergo treatment.
Is it also applicable to those undergoing a letrozole or clomiphene-assisted ovulation, or are those two different issues?
Yes. So for women who have difficulty conceiving, we will do an ultrasound series based on their mucus pattern to do serial ultrasounds to see if they're truly ovulating. If they have an ovulation defect, we can proceed to ovulation medication agents. It's a huge component as well. So there's both medical and surgical approaches to diagnosis and treatment of these underlying issues.
So as always with every medical condition or gynecological condition, it's another tool in a tool set that we can use to try to maximize a couple's chance of conception. Is that fair?
Exactly.
Now, what has been your results? While though maybe anecdotal, does it follow other published data in terms of efficacy, in terms of results with conception?
In general, time to conception does take slightly longer than conventional methods. For us, it's a little different. You usually chart for 2 cycles, undergo testing and treatment, potentially for about a year. The long-term success tends to be higher. There is data published by Dr. Phil Boyle on couples who failed IVF therapy and success rates with this approach of restorative reproductive medicine or NAPRO technology. And it has some cases, it may have a longer time to conception, but a higher success rate. Also, potentially an improvement in pregnancy outcomes. Pregnancies tend to be term healthy singleton pregnancies at a higher rate and less maternal complications, less risk of preeclampsia, et cetera, that you see at a higher rate in the infertility population, but especially high with IVF pregnancies. So it seems to be able to reduce those risks.
For sure. And before we close, Dr. Whittaker, do you have any final thoughts or takeaways, or perhaps even just some personal success stories that you'd like to share with our audience?
Well, first, I just appreciate the opportunity to be able to present about restorative reproductive medicine. And so your listeners may be able to, consider offering more options for patients so there's a greater access to reproductive care. One of my favorite examples is I had a 40-year-old G4P3 with amenorrhea, and she had secondary infertility, fibroid uterus, history of second trimester loss, and her FSH actually was up to 23. And so she was going through ovarian insufficiency. And we were able to, she also had male factor, high abnormal sperm. And with NAPRO technology, we were able to achieve a successful term pregnancy. We did have to use triggers and ovulation medications for her and surgery, but she was able to have a healthy baby.
And with that, I think we'll leave it with our audience. So I want to thank my guest, Dr. Naomi Whittaker, for sharing her experience with NAPRO technology to maximize patients' fertility. Dr. Whittaker, it was great having you and speaking with you today.
It was great being here. Thanks so much for having me.
I'm Dr. Hector Chapa. To access this and other episodes in our series, visit reachmd.com/clinicians roundtable, where you can be part of the knowledge. Thanks for listening.